Doctor warns. The 5 medical checkups I would never get after age 60. A truly surprising truth often hidden within the complexities of modern medicine is that for many healthy adults beyond a certain age, particularly those over 75, routine medical screenings can ironically become a source of more anxiety and potential harm than actual benefit. It might genuinely shock you to learn that when a healthy adult over the age of 75 undergoes a comprehensive full-body scan, an astonishing over 90% of them will receive news that something abnormal has been detected within their system. And here lies the critical, often overlooked detail in the vast majority of these instances that something is entirely benign, utterly harmless, and would, in all likelihood, never have manifested as a health concern throughout their remaining years. Yet, the discovery sets off an immediate chain reaction, a cascade of events driven by caution and concern. The onset of anxiety for the individual and their family, the ordering of additional, often invasive, follow-up tests, uncomfortable and risky biopsies, and in some more extreme cases, even surgical interventions, all performed to address conditions that were never destined to impact their health or quality of life in any meaningful way. As Dr. Robert Harrison, with many years of hands-on experience in medical practice, I have witnessed this very scenario unfold far too frequently, observing the emotional and physical toll it exacts on countless patients. Today, my intention is to shed light on 5 prevalent medical screenings that, once a person reaches or surpasses the age of 70, frequently contribute more to potential detriment than genuine well-being. This discussion is not about encouraging an avoidance of necessary health care, quite the opposite. It's about cultivating an intelligent, discerning approach to your medical care, empowering you to make informed decisions that truly serve your health interests. Therefore, if you are over 70, or if you cherish and care for someone who is, I urge you to remain engaged with this vital information, as what I am about to share holds the potential to spare you and your loved ones from medically unnecessary procedures, avoidable serious complications, and a substantial burden of unwarranted worry. Before we delve into the specifics of each screening, I must articulate with absolute clarity a crucial caveat. I am not in any way suggesting a wholesale rejection of all medical attention, nor am I implying that these particular tests are inherently inappropriate or without merit in every circumstance. My core message is this: as we advance in years, the fundamental calculus governing medical interventions undergoes a profound transformation. What proves unequivocally beneficial and life-saving for someone at the age of 50 may in fact become a source of significant risk and potential harm for an individual at 80. The essence of medical screening is rooted in a delicate equilibrium, a constant balancing act between the anticipated benefits and the inherent risks, and this balance irrevocably shifts as we navigate the journey of aging. It's imperative to understand that every single test I will bring to your attention today undeniably possesses a legitimate and important role within the broader spectrum of medical diagnostics. Indeed, I myself, throughout my professional career, have prescribed these very tests when, based on clinical judgment and specific patient symptoms, they were unequivocally the correct and necessary course of action. However, the critical distinction, the point where we frequently encounter significant trouble and unintended consequences, arises when these tests are ordered routinely, automatically, or simply by default, merely because an individual has reached a predetermined chronological age, without a thorough individualized assessment of symptoms, risk factors, and overall health status. Let's begin our exploration with the first category, whole body scans. You've almost certainly encountered pervasive advertisements for these services, often promising a comprehensive, almost omniscient, complete picture of your health and the alluring prospect of finding problems before they even start. High-end executive health centers frequently command thousands of dollars for these extensive scans, promoting them as a pathway to ultimate peace of mind. On the surface, they appear fantastically appealing, don't they? Who among us wouldn't desire the capability to detect every potential health issue at its earliest, most treatable stage? Yet, Here lies the fundamental issue, a paradox of modern diagnostics. These sophisticated scans are, in a word, incredibly proficient at discovering things, and in the intricate and often nuanced realm of medicine, the mere act of finding things is not invariably synonymous with being helpful or beneficial. The scientific evidence, meticulously gathered through rigorous research, unequivocally supports this assertion. Studies consistently demonstrate that up to a staggering 40% of otherwise asymptomatic adults who elect to undergo whole-body MRI scans will present with some form of finding that subsequently necessitates further investigation or follow-up. A substantial proportion of these findings fall under the umbrella of what physicians term incidentalomas, anomalies discovered entirely by chance, often small and insignificant, that would never have progressed to cause any discernible health issues or symptoms. These can manifest as a minute, benign cyst nestled within a kidney, an almost imperceptible nodule within the lung tissue, or a harmless, non-cancerous growth residing in the liver. Such findings are, in fact, remarkably commonplace as the human body ages. They are, in essence, the internal equivalents of the wrinkles that crease our skin or the gray hairs that silver our heads. Perfectly normal, expected manifestations of the natural aging process. However, once these incidentalomas are brought to light through imaging, the psychological and medical trajectory shifts dramatically. They cannot simply be unfound. Suddenly, the individual finds themselves labeled, often subtly but significantly, as having an abnormality. This designation then places a medical imperative upon their physician, an ethical obligation to pursue follow-up. This follow-up can entail a series of additional scans performed over several months, an invasive biopsy procedure which inherently carries its own array of risks, including potential bleeding, infection, or even false positive results that heighten anxiety. In more unfortunate circumstances, this initial, medically unnecessary scan can inadvertently lead to more aggressive interventions such as surgery or other intensive treatments, all for conditions that, to reiterate, would quite literally have remained dormant and entirely asymptomatic, never bothering the patient throughout their natural lifespan. This distressing cascade of interventions originates solely from a single diagnostic scan that was, from a strictly medical necessity standpoint, never warranted in the first place. Moreover, if the whole-body scan employed is a CT scan rather than an MRI, an additional and very serious concern enters the equation: significant radiation exposure. A solitary full-body CT scan can deliver a dose of radiation equivalent to the cumulative exposure from hundreds of conventional chest X-rays. While the statistically calculated cancer risk attributed to any one individual scan is typically considered small, it is unequivocally not zero. The pertinent question then arises: why voluntarily expose oneself to such a risk, however minute, without a clear, compelling, and established medical benefit? Instead of chasing incidental findings with aggressive imaging, the truly superior alternative, particularly for older adults, is a comprehensive geriatric assessment. This is not a superficial, cursory once-over examination. Rather, it represents a meticulously thorough and holistic evaluation, strategically focused on the factors that genuinely underpin and dictate health, functional independence, and overall quality of life at an advanced age. Such an assessment encompasses a detailed appraisal of functional status, evaluating key metrics like balance, grip strength, and gait speed, simple yet profoundly predictive measurements that far more effectively predict future health outcomes than any high-tech scan. It meticulously reviews all current medications, a crucial step given that older adults frequently manage complex regimens involving 10 or more different pills, where the insidious side effects of these medications are often misattributed to newly emerging medical problems. Furthermore, it delves into critical lifestyle factors: nutrition, hydration, sleep patterns, regular physical activity, and the indispensable role of social connections. These constitute the true foundational pillars of enduring health. A comprehensive geriatric assessment empowers patients with actionable information, providing clear guidance on concrete steps they can take to maintain their health and cherish their independence. Conversely, a whole body scan without specific symptoms or indications often serves only to generate undue anxiety and initiate a potentially harmful succession of further, often unnecessary, diagnostic tests and procedures. Moving to the second item on our list, brain MRI for mild memory lapses. This scenario unfolds with remarkable frequency in clinical practice. An individual over the age of 70 experiences common, benign instances of forgetfulness, perhaps misplacing their keys or struggling to recall the name of an actor. Understandably, their family becomes concerned, often earnestly insisting on a brain scan, typically an MRI, with the noble intention of definitively ruling out serious conditions such as Alzheimer's disease. While the underlying intention is undoubtedly good and rooted in care, the outcome of such an immediate symptom-triggered brain scan for minor memory issues is, regrettably, often problematic and counterproductive. Extensive research has unequivocally shown that an astonishing 94% of individuals over the age of 75 who undergo a brain MRI will exhibit some form of abnormal finding. Pause for a moment and truly consider that figure, 94%. These findings commonly include phenomena such as mild brain atrophy, which in plain terms simply signifies that the brain has undergone a slight, entirely normal reduction in size as a natural consequence of the aging process. It is as much a part of normal aging as a receding hairline or thinning skin. Another frequent finding is the presence of white matter lesions, which appear as tiny, often alarming-looking spots on the brain scans. While these can visually appear concerning, they are, in fact, observed in over half of all elderly individuals and typically signify nothing more sinister than the cumulative effects of years of subtly elevated or imperfectly controlled blood pressure. The significant emotional and psychological challenge arises when, at 78 years old, an individual and their family receive a scan report that starkly mentions terms like cerebral atrophy and white matter disease. To the untrained ear, these medical descriptors sound terrifying, almost like a definitive pronouncement of impending dementia. Yet, to a seasoned and knowledgeable physician specializing in geriatric care, such a report essentially communicates the unremarkable truth that this brain belongs to a 78-year-old person. The profound fear instigated by such findings can irrevocably alter a person's life trajectory. Individuals may begin to doubt their own cognitive capabilities, leading to self-imposed withdrawal from previously enjoyed activities, an erosion of confidence in their mental faculties, and a pervasive sense of dread. All of this transpires solely due to findings on a diagnostic scan that, in essence, have no meaningful correlation with their actual, day-to-day cognitive function. And here lies the most crucial, often misunderstood aspect. These incidental imaging findings do not, in any way, alter the medical management or treatment approach for mild, age-related memory problems. There currently exists no pharmaceutical intervention or medical therapy that can reverse the entirely normal physiological changes in brain structure associated with the aging process. Consequently, in such cases, the brain scan fails to offer any therapeutic benefit. Its primary contribution becomes the generation of anxiety and unwarranted distress. A far more prudent and effective approach involves simple, yet highly informative cognitive testing performed directly within the comfort and familiarity of the doctor's office. Standardized tests, such as the Mini Mental State Examination, MMSE, or the Montreal Cognitive Assessment, MOCA, typically require approximately 10 to 15 minutes to administer. Crucially, these assessments directly measure how an individual's brain is actively functioning, rather than merely providing an anatomical snapshot of its appearance on a scan. If the results of these cognitive tests are within normal parameters, both the patient and their family can be genuinely reassured. Should the tests reveal areas of concern or potential problems, the subsequent step is to systematically investigate and identify any potentially reversible causes of memory impairment. It is a vital and often overlooked fact that numerous memory problems in older adults are indeed fully reversible. Conditions such as vitamin B12 deficiency are remarkably common and, fortunately, straightforward to correct through supplementation. Undiagnosed or poorly managed thyroid disorders can precipitate significant brain fog. Depression, which often manifests atypically in older adults, can frequently present as memory complaints rather than overt sadness. Undiagnosed sleep apnea can critically deprive the brain of essential oxygen during nocturnal hours, leading to impaired memory and cognitive function. Furthermore, a plethora of commonly prescribed medications, particularly sleeping aids and anti-anxiety drugs, can significantly cloud thinking and interfere with memory. Responsible and comprehensive diagnostic strategy should meticulously check for all these reversible causes before any consideration is given to ordering an expensive and potentially misleading brain scan. Only if cognitive testing unequivocally demonstrates a progressive decline over time and all possible reversible causes have been thoroughly investigated and ruled out, might advanced imaging become a justifiable component of a comprehensive diagnostic evaluation. However, for everyday, benign forgetfulness, a brain scan is simply not the appropriate initial diagnostic tool. The third screening on our cautionary list is routine stress tests for the heart. This particular recommendation often takes people by surprise, as the intuitive assumption is, isn't it always beneficial to know the precise state of one's heart? However, the fundamental problem with routinely administering stress tests to asymptomatic older adults, individuals who exhibit no cardiac symptoms whatsoever, is their remarkably high rate of false positives. This means the test results erroneously indicate the presence of a cardiac problem when, in reality, no such issue exists. The question then becomes, why does this phenomenon occur so frequently in the aging population? As we progress through life, the heart and its intricate network of blood vessels undergo various physiological changes that can significantly influence the outcomes of a stress test, often without signifying a dangerous or clinically relevant blockage in the coronary arteries. Factors such as a history of elevated blood pressure sustained over many years, a natural thickening of the heart muscle, left ventricular hypertrophy, or age-related electrical alterations within the heart's conduction system can all independently contribute to abnormal stress test results even when the vital coronary arteries remain perfectly healthy and unblocked. So what happens when an asymptomatic individual receives a false positive stress test result? The unfortunate and predictable sequence of events involves being referred for yet more intrusive and potentially risky investigations. Frequently, this necessitates a cardiac catheterization, a complex and invasive procedure during which a thin, flexible tube, catheter, is carefully threaded through an artery, typically in the groin or wrist, and guided all the way to the heart. This procedure is not without its considerable inherent risks, which include bleeding at the access site, infection, potential damage to the delicate arterial walls, and kidney problems precipitated by the contrast dye used during the imaging. Alarmingly, in a substantial number of these cases, the subsequent catheterization unequivocally reveals that the coronary arteries are, in fact, entirely clear and healthy, thereby confirming that the initial stress test provided an erroneous, false positive reading. Yet, despite the ultimate benign outcome, the patient has endured an unnecessary invasive procedure, complete with its associated risks and the considerable emotional distress that accompanies such medical uncertainty. Even more concerning, albeit rare, the stress test itself can sometimes precipitate serious cardiac events. While uncommon, stress tests have the potential to trigger dangerous heart rhythms or, in very rare instances, even actual heart attacks in susceptible individuals. For a patient experiencing clear symptoms, such as chest pain that reliably occurs with exertion, a stress test is an entirely appropriate and medically necessary diagnostic tool, as we urgently need to ascertain the underlying cause. However, for an asymptomatic individual who is capable of climbing multiple flights of stairs, walking briskly, or engaging in other physical activities without any discomfort or limitations, they are, in essence, successfully passing a stress test every single day through their normal daily activities. Their body's functional capacity is already providing a clear indication that their heart is operating effectively. If the objective is to assess cardiac risk without the attendant pitfalls and false positives of a routine stress test, a far more effective and less invasive alternative exists: coronary artery calcium (CAC) scoring. This procedure involves a rapid, low-radiation CT scan specifically designed to quantify the amount of calcified plaque present within the coronary arteries. A CAC score of 0 provides strong reassurance, indicating a very low risk of experiencing a heart attack in the ensuing years. Conversely, a higher score serves as a powerful indicator that proactive and aggressive preventive measures, encompassing both medication and comprehensive lifestyle modifications, are urgently warranted. CAC scoring delivers genuinely informative and actionable data without initiating the potentially harmful and anxiety-inducing cascade of interventions that so frequently follow a false positive stress test. Our fourth crucial screening for reconsideration is colonoscopy after the age of 75 to 80. Let me be unequivocally clear on this point. Colonoscopy, when appropriately timed and indicated, stands as an exceptionally effective and vital screening tool. I wholeheartedly and emphatically endorse its initiation, typically commencing around the age of 45, as it has been undeniably proven to save countless lives by facilitating the early detection and removal of precancerous polyps before they can evolve into malignant tumors. My specific concern, however, pertains to the continuation of routine colonoscopies into advanced old age, particularly when an individual's prior screenings have consistently yielded normal results and they are completely asymptomatic. The rationale behind this caution is multifaceted. The primary, life-saving benefit of a colonoscopy lies in its capacity to prevent the development of colorectal cancer that would typically manifest 5 to 10 years in the future. Consequently, if an individual's projected life expectancy is less than 10 years, whether due to advanced age itself or the presence of other significant coexisting health conditions, the statistical likelihood of them deriving a meaningful, life-prolonging benefit from routine screening diminishes significantly. Simultaneously, the inherent risks associated with colonoscopy progressively increase with advancing age. The bowel preparation alone, which necessitates consuming large volumes of potent laxatives, can pose substantial hazards for older adults. This rigorous preparation can induce severe dehydration and dangerous electrolyte imbalances, particularly perilous for individuals with pre-existing kidney disease or congestive heart failure, where it can trigger acute and serious complications. The sedation administered during the procedure itself also carries heightened risks in the elderly population, including episodes of acute confusion or delirium, breathing difficulties, and potentially dangerous drops in blood pressure. Beyond these, there is the ever-present, albeit relatively rare, risk of perforation, a tear in the delicate colon wall. While the overall incidence of perforation hovers around 4 per 10,000 colonoscopies, this risk demonstrably escalates in individuals over 75, and particularly for those beyond 80 years of age. The colon wall naturally thins and becomes more fragile with advancing years, rendering it more susceptible to tearing during the procedure. A perforation constitutes a genuine surgical emergency, often necessitating major abdominal surgery, which in some cases, unfortunately, results in the creation of a colostomy bag. For an 80-year-old individual, such a traumatic event can, tragically, mark the definitive end of their cherished, independent living. These shifts in the benefit-risk balance are clearly reflected in major medical guidelines. The respected U.S. Preventive Services Task Force, for instance, explicitly recommends that decisions regarding colorectal cancer screening for individuals between the ages of 76 and 85 be made on a highly individualized basis, taking into meticulous consideration their overall health status, existing comorbidities, and comprehensive prior screening history. Furthermore, they issue a clear recommendation against routine screening after the age of 85. This guidance does not imply a complete disregard for colon health once an individual reaches 75. Rather, it signifies a crucial pivot from routine screening to vigilant surveillance. It underscores the paramount importance of being acutely aware of potential warning signs and reporting them to a physician without delay. These include persistent changes in bowel habits, the presence of blood in the stool, unexplained weight loss, new-onset anemia, or persistent abdominal pain. If any of these symptoms emerge, age becomes an irrelevant factor, and a thorough medical investigation is unequivocally warranted. Moreover, proactive prevention continues to play a pivotal role. A high-fiber diet, rich in fruits, vegetables, whole grains, beans, and lentils, remains one of the most effective and safest strategies for promoting optimal colon health, as it nourishes beneficial gut bacteria that produce anti-cancer compounds. This dietary approach offers profound benefits for the entire body, extending far beyond the colon, and is a considerably safer and more sustainable strategy than engaging in repeated high-risk colonoscopies in very advanced age. Our fifth and final screening that often warrants cautious reconsideration is PSA testing for prostate cancer in men over 70. This particular test has been a perennial source of vigorous medical debate and controversy for many years, and for very compelling reasons. The prostate-specific antigen, or PSA blood test, has unfortunately been implicated in creating what many medical experts describe as an epidemic of overdiagnosis and overtreatment of prostate cancer. A crucial distinction that sets prostate cancer apart from many other malignancies is its typically indolent, slow-growing nature in the vast majority of men, particularly as they advance in age. Autopsy studies, conducted on men who have died from other causes, reveal a startling statistic. Up to 80% of men in their 80s, when autopsied, will show evidence of prostate cancer. Yet, the overwhelming majority of these men died with prostate cancer, not from it. The cancer was merely an incidental finding, quietly residing within their bodies, never causing any symptoms or problems throughout their lives. The inherent problem with the PSA test lies in its fundamental inability to differentiate between these aggressive forms of prostate cancer that genuinely require prompt and decisive treatment and the multitude of slow-growing, indolent cancers that pose no threat and will never cause harm. Consequently, the PSA test leads to the detection of a vast number of these clinically insignificant cancers, and once an individual is informed that they have cancer, the natural and understandable human instinct is to seek immediate treatment, regardless of the cancer's biological potential. However, treatment for prostate cancer, particularly through surgery, radical prostatectomy, or radiation therapy, is by no means a minor undertaking. Both modalities carry significant and often permanent side effects. Surgery frequently leads to permanent urinary incontinence and erectile dysfunction, while radiation therapy can cause similar debilitating issues in many men. These life-altering side effects can dramatically and profoundly impact an individual's quality of life, often outweighing any potential, albeit theoretical, benefit derived from treating an indolent cancer. The U.S. Preventive Services Task Force, after meticulously reviewing all available scientific evidence, concluded that for men aged 70 and older, the potential harms associated with routine PSA screening unequivocally outweigh any potential benefits. the statistical probability of finding a prostate cancer that would, in actuality, be life-threatening and cause death in this age group is remarkably small. Conversely, the likelihood of overdiagnosis and subsequent harmful overtreatment is substantial. The task force estimates that rates of overdiagnosis are more than 15 times higher in men over 85 compared to men in their 50s. What about men with a strong family history of prostate cancer or other identified risk factors? These factors are absolutely crucial and undeniably shift the delicate benefit-risk balance, potentially warranting a discussion about screening even after the age of 70. However, such screening decisions should always be the outcome of an in-depth, personalized discussion between the patient and their physician, rather than an automatic routine test. This informed conversation should meticulously explore the real statistical probabilities, the tangible risks, and most importantly, what truly matters most to the individual patient regarding their health goals and quality of life. For men who are indeed diagnosed with a very low-grade prostate cancer, a strategy known as active surveillance often represents the most judicious course of action. This involves meticulously monitoring the cancer's progression without initiating immediate aggressive treatment, unless and until it shows definitive signs of becoming more aggressive or clinically significant. Regular PSA tests, alongside periodic biopsies, serve to keep a vigilant eye on the cancer's behavior, allowing the patient to avoid the life-altering side effects of unnecessary treatment for a cancer that, in all probability, would never have caused them harm. So, there you have them. 5 prevalent medical screenings that, for individuals aged 70 and beyond, frequently generate more problems and distress than they genuinely resolve. These include whole-body scans that uncover benign, harmless abnormalities and subsequently initiate a burdensome cascade of unnecessary follow-up testing and interventions. Brain MRIs performed for mild, age-related memory concerns that often serve only to create anxiety without furnishing truly useful or actionable clinical information. Routine cardiac stress tests, which exhibit unacceptably high false positive rates in older adults, leading to invasive and unnecessary procedures. Colonoscopies performed after the age of 75 or 80, particularly when previous screenings have consistently been normal and the patient is asymptomatic, given the increased risks and diminished benefit in very advanced age. And finally, PSA testing in men over 70, a practice that frequently culminates in the overdiagnosis and overtreatment of indolent, slow-growing prostate cancers. What is the unifying thread, the common denominator, that connects all these diverse screenings? They are all prime examples of a diagnostic paradigm focused on actively searching for problems in individuals who are entirely asymptomatic, people who exhibit no discernible symptoms or complaints. And as we continue to advance in age, this particular mode of proactive, undiscriminating searching becomes progressively less likely to genuinely help us, and conversely, significantly more likely to inflict harm. I wish to re-emphasize, with the utmost sincerity, that this discussion is not an argument for avoiding necessary medical care. Rather, it is a passionate advocacy for smart, judicious, and patient-centered medical care. It is about strategically directing our healthcare resources and focus towards interventions and assessments that demonstrably improve genuine health outcomes and enhance overall quality of life. In this context, a comprehensive geriatric assessment unequivocally surpasses the utility of a whole-body scan every single time. Brief, targeted cognitive testing proves far more effective and less anxiety-inducing than a brain MRI for the evaluation of mild, age-related forgetfulness. Being intimately familiar with potential warning signs and diligently maintaining a healthy, proactive lifestyle offers superior benefits to routine colonoscopies in very elderly individuals. And, perhaps most importantly, engaging in honest, open, and empathetic conversations about individual goals, values, and preferences fundamentally trumps the automatic, unthinking application of PSA testing. The overarching objective of healthcare for individuals over 70 should not be merely the exhaustive pursuit and discovery of every conceivable potential problem, regardless of its clinical significance. Instead, the paramount goals must be the maintenance of functional independence, the preservation of autonomy, and the sustained enhancement of quality of life. Sometimes, the most profoundly powerful and beneficial action a physician can undertake is precisely not to order a test, but rather to sit attentively with a patient, to genuinely listen to their concerns, fears, and aspirations, and to collaboratively focus on what truly matters most to that unique individual, ultimately helping them to remain active, socially connected, and deeply engaged with the richness of life. If there is but one singular message I implore you to internalize and carry forward from this discussion, it is this: you possess an inherent and fundamental right to ask questions about your healthcare. When your doctor recommends a specific test or procedure, you are absolutely empowered to inquire, why is this test being recommended? What specific course of action will be altered or decided upon based on the results of this test? What are the potential risks, however small, associated with this procedure? And critically, what are the implications, or what happens if I choose not to undergo this particular test? These are not confrontational inquiries. On the contrary, they are the hallmark questions of an informed, proactive patient who is actively and intelligently taking charge of their own health journey. The ideal doctor-patient relationship should always be founded upon a true partnership. You, as the individual, possess an unparalleled understanding of your own body, your personal values, and what holds the most significance in your life. Your doctor, in turn, possesses expertise in the vast landscape of medical science. Together, in collaboration, you can forge decisions that are not only medically sound, but also deeply meaningful and appropriate for you as a unique individual, rather than merely adhering to a generalized guideline or a statistical probability. So the next time one of these specific tests is suggested, I encourage you to pause, to critically reflect, to ask those pivotal questions, and to make a truly informed decision, because the ultimate objective extends far beyond simply living longer. The true aspiration is to live well, to live with dignity, to maintain independence, and to experience enduring joy. And sometimes, perhaps counterintuitively, the most effective way to safeguard and protect those invaluable aspects of life is to courageously and thoughtfully say no to a medical test you genuinely do not need. We appreciate your attention. If you found this information to be valuable and enlightening, please consider sharing it generously with others within your social circles who might similarly benefit from these insights. Furthermore, I encourage you to subscribe to the channel for a continuous stream of evidence-based advice on how to navigate the aging process with optimal health and well-being. Please also feel free to leave a comment below. I am genuinely eager to hear your personal experiences. Have you ever felt undue pressure to undergo a medical test that you harbored reservations about? How did you approach and manage that situation? Your stories and perspectives are incredibly valuable to this ongoing conversation. Until our next discussion, please strive to stay well and always remember, smart healthcare is fundamentally about possessing the wisdom to discern when to confidently say yes, and just as importantly, when to thoughtfully say no.